Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the Prolonged Field Care Podcast. This is Paul, and I'm joined today with Dennis, and we're doing a special episode to go over what we've accomplished over the last 5 years thanks to your help and the Special Operations Medical Association. I wanted to go over some of the current initiatives that we have working, within our organization, however small it may be, and then even greater outside of our organization, things that we're aware of that you may not be aware of as a longtime listener or if you're just listening to this for the first time. So we've been doing this since 2013. So this is, like I said, the 5-year anniversary. And since then, we've had the Joint Trauma Service collaborate with us, and we have clinical practice guidelines for special situations. We have analgesia and sedation. We have crush injury, burn injury, TBI, and they're geared to the Role 1. So anywhere from the battalion aid station, PAs, battalion surgeons, down to the medic, special operations combat medics, and everyone that could be considered Role 1. We've also worked with different entities in getting telemedicine set up. So we have now the advisor line. You can look that up on our website. The Society of Critical Care Medicine is also looking at adopting some of our principles in a new FCCS austere and operational environments course. The JPC 6 up at Fort Detrick, who awards research grants, they have a prolonged field care section. There's also JPC 1 that's looking into training in prolonged field care. We have prolonged field care training going on at the SOCM course at the JSOM-TC, the SFMS course. We have parts of it in the SOCMS and SFMS refreshers. 1st Special Forces Command has the SOF austere critical care course for non-medics. The NATO SOCM course going on. The Nordic SOCM course touches on it. The Expeditionary Combat Medic course down at Fort Sam. The Delayed Evacuation Casualty Management course at Fort Bragg. That's for 68 Whiskeys, and that's run out of Womack at the Taylor Sandry building. We also have many other unit-level training events going on. And of course, a lot of this information can be found at our website at prolongedfieldcare.org. So we wanted to kind of reorient the community, anyone that's talking about prolonged field care, doing training, and talk about what it is not first. So it's real easy to just throw out a boring definition, but we want to make sure that everybody's kind of on the same page as far as what it's not, and then we can talk about what it is later. We just wanted to make sure that it is not a skill set. It's not something that you can get a certification in. You can go to different training courses, you can get experiences, but prolonged field care at its essence is good evidence-based medicine in bad situations, using the resources and the environment around you. So it's not only trauma. A lot of the stuff that we focused on has been trauma. It's kind of one of those, A, it's sexier, but B, it's also easier to gain support from different entities. The joint trauma system looks at trauma, but there is no joint non-trauma system. There are other things that we may be looking at in the future. We're looking at sepsis right now. That could be due to trauma or just an infection that somebody has. If you have ideas for any non-trauma related issues, we can take a look at those as well. So it's not just nursing care. I've heard that put out before. Hey, that's a whole nother discipline in and of itself. People go to school for years and years to give good nursing care. Dennis, do you have anything you wanted to say about that?
I think just good medicine is good medicine regardless of the label you put on it. Labeling prolonged field care is just nursing care, I think is saying putting in a central line is just an IV. Yeah, part of it is nursing care, but what it is more of a holistic approach, I think, to taking care of a patient and having an entire hospital staff packed into 1 or 2 people with some assistance from the non-medics.
Yeah, I would definitely agree with that. So we also want to say that prolonged field care is not just about Africa. That's kind of where it was born out of, the concept, or, the time frame that we were going to Africa, and NATO held a meeting and coined the term prolonged field care, and it kind of all fell together at the same time and same place. But you could easily be involved in a PFC type situation in Afghanistan, like we saw with the Marja incident, or in PACOM, or anywhere else in the world that, your evacuation is delayed. This is a big one. It's not a replacement for tactical combat casualty care. And Kotze and the Deployed Medicine app have some great resources on there that we really urge you to go check out the app, check out the website, and you really have to master those. We say this as much as we can, but a lot of times people get confused and they want to just, hey, prolonged field care is the new next best thing. And it's the next thing in that you better master T-TRIC first before attempting prolonged field care, because those basic principles are going to be what saves the life. Prolonged field care is not a replacement for. I can't say that enough. So it's not an automatic 72-hour security blanket. If you have this training, now you can go out and it mitigates all risk, because you're still not doing surgery in the box. You're not doing craniectomies. You're probably not doing thoracic surgery. And so if you're in a situation that becomes kinetic, or you know that's going to be kinetic, you probably need to have a surgeon with. That's one of those prolonged field care truths that we said long ago. It is not a mitigation for all medical risk, because it doesn't matter what you train on. That real world situation that you're going to be faced with is probably going to be different than the scenario that you trained on. It's also not a replacement for a critical care team. Now, you can enable a medic or a provider.
You could use that to inform a medic on steps for further care, processes that would have happened in a hospital later on, things that they're going to look for. But it's definitely not a critical care team, because you do not have critical care equipment and gear. You have what you have on your back or in your truck or in your house, but you don't have the experience that they do. You don't have the level of training that they do. What you're doing is just becoming more informed on how to monitor for things, document for things, and how to watch out for pitfalls further on down the road.
Yeah, really, that anticipation is huge. So now that we talked about what prolonged field care is not, what is it? So I think it's Doug that likes to say it's holding on to a sicker patient than you can care for longer than you want, with fewer resources than needed, in a place that you don't want to be. So it's a bad situation. It's an operational problem. It's a logistical problem. It's a knowledge problem. And it's just what you're left with. So you don't plan to have prolonged field care. We say this over and over again, but we really can't say it enough. But that should not be the P in your PACE plan. It's not your primary. This should be like your C or your E, your emergency, not your go-to. That training is going to enable you to understand the risks better, and probably enable you to communicate those risks to your commanders or your medical directors or whoever else is out there that you have to convince. Also, you could consider it the management of complex patients over extended periods of time in an austere, resource-constrained environment. So that's pretty much what it is. It's beyond doctrinal planning timelines, in that you don't plan to do prolonged field care. If it happens to you and you're prepared for it, all the better. But you should make every effort to plan so that you're not in that situation.
Yeah, I think it's a lot like survival training, either military or civilian. Nobody plans on being in a natural disaster or being stuck in the middle of nowhere and having to survive just by their wits and what they can find. But that doesn't mean you don't train in that as well. Just because the risk is out there, in order to mitigate that risk, you go to the training. I think the same as prolonged field care. Nobody plans on weather or mechanical failure or enemy or whatever the situation is, delaying medevac or stopping medevac altogether. You don't plan for that to happen, because if that's the plan, then you change your plan. It's to help mitigate the risk in case something goes wrong, to give that person who is wounded or is sick the best chance for survival.
The other thing I would say, when you're doing this training and you need to justify it to someone, who might be writing a check for you to be able to do this training, to a commander who might be allotting you time to do this, is that having that deeper understanding of your patient, what's going on with them and what will be going on with them later, is going to give you more motivation to do those initial T-TRIC interventions in a proper manner, in a timely manner, so that you don't have those complications from improper treatment initially.
Yeah, and just becoming more informed in medicine itself. I mean, you learn the whys of why you're doing something in T-TRIC. Why are you doing it this way? And what happens if you don't do it this way? And some of the other techniques, for example, pain control. You just learn better techniques that allow you to do things smarter, even initially.
This working group was initially the extended care working group. When we started a website, it was an austere medicine website. It was kind of all over the place. But when that prolonged field care term came out, that kind of started allowing people to speak the same language. And that's why we just wanted to make sure everybody's on the same page. If you're holding on to a patient in a Role 1 or Role 2 facility because you're a small team, you still don't have medevac, you could call it advanced field care, austere critical care, emergency critical care. There's all these different terms out there, and they're all slightly different, but when it gets down to it, the basis of all this is providing good medicine for your patient, despite the fact that they're not where they're supposed to be. And that's at a facility that has a higher level of care, resources, and personnel. I think, like Dennis said, you train for survival situations. You also train for mass casualty situations, and those are worst case scenarios. And I think prolonged field care is one of those kinds of worst case scenarios. Your provider is likely overwhelmed. The resources are overwhelmed. You can't get certified for a mass cal event, but having a plan for it can mitigate some of that morbidity and mortality that you may experience in the mass cal. And I think that translates over to prolonged field care really well. Everybody pretty much understands mass casualty situation, but if you just have one patient and you're overwhelmed with the injuries of that one patient, it's a very similar situation. Originally, the Prolonged Field Care Working Group said that prolonged field care should only be done by a SOCM level trained medic. And the reason that was said initially, and still many people believe this, is because they have that baseline knowledge and also that baseline mastery of all the trauma care. There are many medics and their supporting providers that still have never heard of that TRIC, and that lack of standard tactical combat casualty care does not lend itself well to a prolonged field care situation. Now, you can't say that all medics can't do prolonged field care, but you really do have to master the basics before you move on to the next higher level thing. Also, we see a lot of guys, a lot of medics, 68 Whiskeys, a lot of corpsmen, their providers do not trust them with the basic, let's say ketamine, doing cricothyroidotomies, whole blood transfusions. And if you can't do that stuff, then your patient's going to have a worse outcome because of just that, not because you didn't have the prolonged field care training. It's because you didn't have the mastery of tactical combat casualty care. So a lot of these things that we talk about in prolonged field care are in existing 68 Whiskey scope of practice. Now, it may be a level 3 task or something such as a chest tube, but we hear of medics who go out and do drop zone coverage, and they're not allowed to carry Tylenol to give to patients on the drop zone. So if that is the case, if your provider can't trust you, or if you're a provider and you can't trust your medic, you cannot be doing prolonged field care and talking about ketamine drips and sedation and everything else that goes along with it. You also need hands-on real sick patients in hospitals. And I know, many, many years ago when I did my 68 Whiskey rotations, we went to BAMC for a couple of days. We got to go to the burn unit up there, and it was an amazing experience, but I wasn't able to take it all in. I didn't know what was going on with the patients at the time. It was just kind of overwhelming. I think it was 2 or 3 days long, and then that was it. You're off to the force. So spending a month, 2 months or more in those hospital rotations really do give you an appreciation, and you have the time to let a lot of that stuff soak in as you're exposed to it.
I also think it has to do with the mission set themselves. Your SOCMs, your 18 Deltas, your SOIDCs, just your special operations medic in general are just going to be more likely to be in a situation where you'd have to do prolonged field care. I would love for every medic in the DoD to be up to that level that they can handle patients for more extended periods of time. But, as it is, if you're very close to a provider, or a provider is attached to your unit and you're not leaving that provider's reach, you should be leaning on your provider to give you those decisions or make those decisions and give you that direction, versus a special operations medic will be outside of that reach and will have to make those decisions on their own. So that is, I think, the baseline.
Yeah, that's a good point. If you look at an SF battalion, you might have 18, 21 teams in 10 different countries, and you have one PA and one battalion surgeon, and they may not even be deployed with you. For a lot of the prolonged field care tasks are already 68 Whiskey tasks. 68 Whiskeys can give blood. They can trend vital signs because they can take vital signs. It's just the matter of marking them down in a visual way. You can do a problem list, and that will help you anticipate some of the issues that you have. There are courses out there, the Ranger RFR and ARFR, and then there's the SOFAC training, and we teach non-medics some of these skills, just in the case that they're in some of these worst case scenarios. So I have a checklist here in front of me, and I'll post this in the show notes. It says, so what might work then? You know, if you think you might be in a prolonged field care situation, if you're thinking about doing trainings, you got to make sure all medics and higher are mastering T-TRI-C for medical providers. So if you go on the Deployed Medicine app or website, there's a specific set of guidelines for medics, for PAs, and for physicians. You also need all non-medics to master the T-TRI-C for all combatants. That's everybody in the unit. So those are the things that you have to get 100% on before you start moving into the other areas looking at prolonged field care. That includes whole blood training for every one of those people that are involved. You need command support, so you should have your commanders, your first sergeants involved in this. You need some honest medevac planning. What is your worst case scenario? If your worst case is that it's going to take you 3 hours to drive to your PA, then maybe that's all you need to train for the time being. If you look at my worst case might be 24 or 28 hours like we talked to some guys, then that should be your training goal. This should involve the whole team. It should be a collective effort. Make sure that you do telemedicine consults and you get providers that you can trust on the other line, like the advisors. Utilizing appropriate NGOs. If you're in an area of the world where that is a possibility, that can help alleviate some of this risk. Just make sure that you vet those organizations and facilities before you lean on them. Same goes for utilizing approved host nation facilities. And like I said before, it's the E in your PACE plan. It's not the P. So we'll also post that checklist on prolongedfieldcare.org. So when you talk about what you should actually be doing, you need to have your proper T-TRI-C, your March sequence. So that's your March E, Pause B sequence. If you don't know what that is, it'll be in the show notes as well. You need to have your whole blood program, whether it's OLO titer or you're getting it from the Armed Services Blood Program. You need to have all your members team trained. You need to be able to do sleep rest cycles properly. Then you can start looking at the prolonged field care Ravines mnemonic that goes over our 10 core capabilities, which are all over the website. One of the things that can really help you out is an exhaustive, comprehensive secondary survey. That way, when you go from head to toe on the patient, you're going to identify every little problem, even if it's something that you caused. If you gave a patient an IV, that should absolutely go on the problem list, and then you should have a plan for maintaining that. You're going to have a corresponding care plan. You're going to be able to trend vital signs on a dedicated flow sheet, and you should do this in realistic scenarios with your whole team. So since this is a 5-year anniversary episode, we just want to make sure that everybody out there knows this is a Special Operations Medical Association working group. Jamie Riesberg is the chair of the working group and the steering committee. Myself and Dennis are also on the steering committee, and we have many subcommittees that deal with education, knowledge management, telemedicine, and we have hundreds of SMEs out there and medics that contribute when needed. This has been a unique situation. It's not like other working groups or committees in that we don't have formal meetings. We don't have a budget. I think per year we spend about $150, and it's not us. It's Special Operations Medical Association working group, and they actually provide the Libsyn account that this podcast is hosted on, and then they pay the bills for the $79 a year for prolongedfieldcare.org. So that allows us to do some work in our free time and other SMEs to contribute when it's convenient and there are no mandates. So you'll see sometimes we'll have a bunch of podcasts that come out, and there may be 2 months that go by and we don't get one out on time. It's because we're busy with our actual jobs. Right now, Colonel Sean Keenan is recently retired, so he left the working group, but he is still part of the Special Operations Medical Association. We have Lieutenant Colonel Doug Powell, who's been one of our biggest supporters and contributors from the beginning. He's going to be an advisor in a reserve capacity now that he's transitioned off of active duty and he's doing critical care out in the real world. Probably still be hearing from him, although it may be on a less regular basis. And then we've had other medics come and go in advisory roles to the steering committee. We have over 40 podcasts. If you hadn't noticed on the website, we have 9 clinical practice guidelines now with the addition of the remote damage control resuscitation. There will be a podcast on that hopefully soon. And then we have many more blog posts and recommendations. So it's a little overwhelming, but when you start looking at all the resources that have been made by all these contributors, I started counting pages. It's actually over 350 pages. And I've had requests, hey, why don't you guys make a book or a manual or a smart book? And really by the time we even start doing something like that, because I've looked at it a couple of times, 2 more CPGs will come out and then I've got to, edit the thing and put it together. So I think it's just going to be a collection of files that constantly changes. And you can find those on the JTS website or prolongedfieldcare.org. So if you need to find the official CPGs or you want to find our original position papers, we had a telemedicine position paper come out not long ago, and they're all on there to find. So that's all we have for this episode. If you have any questions, be sure to get on prolongedfieldcare.org. You can get in the comments section, ask us questions there. There's a Facebook page, there's Instagram. We have some content on there. Wherever we can reach medics, we're trying to get out there and get the word out so that whoever's out there doing this hard job, that they don't have to recreate the wheels that other people have created. So I think we're a pretty good nexus. If you also have something you want to share with other people, please send it in. You can get credit or remain anonymous, however it works out for you. Some people don't want to be named, and we really appreciate your listening.
That's it for today's podcast. Be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.